I will also announce the names of the board members when addressing them and on first and second motions. At this time, I would like to read the mission statement of the Texas State Board of Dental Examiners. The mission of the Texas State Board of Dental Examiners is to protect the public health and safety and promote high quality and safe dental care by providing enforcement, licensing, peer assistance, and related information services to licensees and their patients. Ms. Nichols, do you mind calling roll to confirm that we have a quorum present?
Yes, ma'am. Dr. Linda Burke.
Present.
Dr. Yvonne Maldonado.
Present.
Dr. Brian Henderson.
Present.
Ms. Lois Clamro.
Present.
Ms. Catherine Sisk.
Present.
Dr. David Yu.
Present.
We have a quorum.
Thank you. Okay, so moving on to our first agenda item. We are going to discuss the committee recommendation and possible action on rulemaking pertaining to Botox. And at this time, I would like to ask Ms. Studdard to lead our discussion.
Thank you, Dr. Burke. So at the previous board meeting, staff was asked to look into whether the board should revise the current policy statement regarding facial cosmetic surgery or treatment, or to implement a rule on this topic. After reviewing regulations from several other state boards, there aren't many rules pertaining to this topic, although I did find rules from both Louisiana and New Jersey, and both those rules are in your board materials for your review. Also in your materials is a written comment from Dr. Malkmacher from the American Academy of Facial Aesthetics. It was a comment that he submitted at the previous board meeting. The committee should keep in mind that a policy statement may constitute a de facto rule, which cannot be enforced without required notice and comment period. Rather than revise the policy statement, I would advise the committee to withdraw the board's policy statement and propose a rule pertaining to this issue so that it can go through the rulemaking process. However, if the committee decides not to propose a rule, the agency will continue to review any potential violations on a case-by-case basis to determine whether the licensee was practicing within the scope of practice and according to the standards of care.
Thank you. Okay. Yes. Dr. Henderson?
Thank you, Dr. Burke. Lauren, by your statement, you're recommending that we withdraw this and propose a rule?
My recommendation is that, I believe it was maybe mentioned at the last board meeting that we should look into whether we should revise the policy statement. I wouldn't advise that. I would advise not to revise the policy statement because we can't rely on it. I would actually advise withdrawing it and proposing some type of rule so we can go through the rulemaking process. But that's under the discretion of the committee. If you don't do that, if you don't propose a rule, we'll continue to look at the cases on a case-by-case basis.
And does staff have a proposed rule or language that they all thought about?
So there are two rules.
Is it on our information, a rule that you proposed?
No, not that staff proposed.
Okay.
But there are two rules for your review from Louisiana.
Yeah, I saw those, but there's no language written by staff yet
Right, not yet.
for this. Okay, thank you. I just wanted to get clarification.
Yes, Dr. Yu? Thank you, Dr. Henderson.
Should we have I think Dr.
The committee like to hear from him now.
That's okay.
His audio's activated. There it is.
Oh, he's on there now. Yeah.
Hello,
Dr. Malkmacher.
Yes, hi.
Hi, how are you?
Good. How are you today?
Great, thank you for being here. It is, the dental practice committee is present along with staff, and you're welcome to speak if you would like the floor at this time.
Okay, I really appreciate it and thank you for the opportunity. And I know I'm limited to just a few minutes, so I'll keep it just a few minutes. I'm just here to talk about the policy statement that the Texas Dental Board has had regarding, I think it's titled facial cosmetic surgery. I've spoken to the dental practice committee before, and for the last 10 years have interacted with the Texas Dental Board on a variety of levels, even going all the way back to when this thing was created, when really it wasn't as much as, it was just coming into dentistry with Botox and fillers and injectable treatment. But now we are in 2021 when it is pretty much standard mainstream dentistry across the country. And certainly there are so many uses for injectables in just, within the scope of dental practice, even the way it's written in Texas as well, which is not that different from many other states. And being that, the policy statement, really, when you look at your policy statement, everybody hates the policy statement. Everybody hates policy statements in general. It's really the only one, it just confuses everybody. It's the only policy statement that Texas has regarding an actual procedure. And the way that most states have really taken a look at this is the way they answer most questions when there are new things that come up in dentistry, is if it's within the scope of dental practice it's in. If it's out without, it's up to the dentist to go ahead and make sure and document appropriately and make sure that you can prove that it's within the scope of practice. And certainly that is the case for Botox and fillers for aesthetic and therapeutic purposes, as we know for the last 10 years plus. And it's interesting, in Texas, there have been lots of, the AFE probably had our first training in Texas in 2010, and we had some sitting dental board members at the time take the training. We've had certainly many of them over the years take our training too. But when you have the fact that we've given the course at the ADA annual meeting in San Antonio, I believe it was in 2014, the AGD just had an Austin meeting, and there was Botox and dermal fillers and even some advanced procedures. The problem with the policy statement, and again, I don't want to take up your time because I could talk for 20 minutes just on this. It's contradictory. It's factually wrong. It speaks in double negatives. It really prevents patients from getting the absolute best treatment that's available now in dentistry with the use of Botox and fillers for a number of dental treatments, aesthetic and therapeutic. It's just kind of ironic because in the state of Texas, where medical assistants can go ahead and give Botox and dermal fillers, certainly much less trained than dentists, you've got this policy statement that I know the dental members of the dental board staff, I know dentists who have been called to the dental board and reported on this policy, and they've come to the dental board, and the dental board has told them, well, we really can't enforce anything in this policy. There's just no need for anything. And I think ultimately, there's a proven track record of Botox and fillers in dentistry now for 10 years. In 2010, it was a different discussion, which probably is what, the people thought the policy statement was a good idea. But at this point in time, Texas dentists and certainly dentists around the country have proven that there is a great safety record of Botox and fillers, and its use in dentistry is pretty standard within the scope of dental practice. And here's the big key, is when dentists learn how to document it very well. And that's something that certainly the AFE and all of our certification courses really teach dentists how to do. We teach them all the dental uses, cosmetic and therapeutic, all over the head and neck. And that is something that, certainly at this point in time, at least in my belief, and it's been like that for a long time, let the Dental Practice Act speak for itself like it does in every other state. And there's really no need for this policy statement as it is. And, that's pretty much what I wanted to say, and I'm happy to answer any questions if any of you had any questions for me.
Thank you. Ms. Palermo has a question for you.
Yeah, I did have one question, and you might have answered it in the beginning, but I just missed it. But I know the policy statement refers back to limiting everything like that, the Botox and fillers, to the specialty of oral and maxillofacial surgery. So are you opening that up for all dentists or leaving it with the OMSs?
Well, the policy statement as it is, again, it makes the statement that it opens that, and we're not talking about all Botox and dermal fillers. We're talking about isolated cosmetic purposes of Botox and fillers, according to the policy statement, is permitted only for those dentists in the specialty of oral and maxillofacial surgery. It doesn't say that anywhere in the Dental Practice Act. So there's really no basis for that statement on here. And I mean, what can I tell you? The answer is yes. However, let me qualify that, because what most people don't realize is that 98% of Botox and dermal filler treatments have an absolute combination of aesthetic and therapeutic purposes at the same time. And most of them that are delivered in the dental office have that same situation, because most of it's related to dental aesthetics around the mouth, soft tissue, and those kinds of things. So I mean, I would say yes to your answer, because most states are like that as well. Dentists are allowed within the scope of dental practice to use it for purely aesthetic and or therapeutic purposes. But just about every treatment has got, again, 98% of the treatments have the combination anyway. So it's, to your question, it would, isolated cosmetic purposes would really be very isolated to just a very, very small percentage. But I would say, like most states, and certainly the Dental Practice Act in Texas, there is absolutely no exclusion for any cosmetic procedures. And that's why I was saying that this statement in the policy statement, according to the Dental Practice Act, really there's no basis in the Dental Practice Act, because if the Dental Practice Act did in Texas have an exclusion of cosmetic only procedures, well, that would also mean that dentists could not do porcelain veneers or dental whitening, which are isolated cosmetic purposes. And really don't have any therapeutic benefit for that. So, you know, that's some of the discrepancy between the policy statement and the Dental Practice Act. And again, I've heard from dental board staff, and I've heard from dentists who have who've had appeared in front of the Texas Dental Board because there was a complaint based on this policy, where basically everyone threw up their hands and said, we really can't do anything about this anyway. But they would, you know, they may find something else in the practice. And let's be honest, you know, at least from my experience, because I do hear from Texas dentists that may, you know, be called to the board because, you know, someone reported them for this policy. It's not patients who are doing it mostly. It's usually dental competitors who are reporting other dentists. So, you know, that's why I think this policy statement has really been frustrating to everybody, whether it's Texas dentists, the dental board members, dental board staff over the years. And I would really highly recommend let the Dental Practice Act speak for itself. It's up to the dentist to make sure that they document it appropriately and get everything within the scope of dental practice. And again, we've taught that for 10 years. So there's certainly ways to go ahead and make sure that it's done appropriately.
Thank you. Dr. Yu also would like to make a comment.
So Dr. Mockmacher, I know the statement is how many years old, like 11 years old now. And in that time, have you, you know, our concern is public safety.
Sure.
And have you heard or seen or testified on patient harm with these procedures? I know it's not permanent, but what's your experience like with that?
Right. So both to your point, Dr. Yu, both Botox and dermal fillers and PDO threads, these are all temporary procedures lasting 3 months, 6 months. They're among the safest procedures. And I've taught implants, I've taught dental porcelain veneers, I've taught, you know, all kinds of all phases of dentistry in 40 years of teaching. No question, because of their temporariness, if that's a word, they are among the safest procedures that are in dentistry right now. I would say rarely will you ever get, I don't know if the Texas Dental Board has ever gotten a patient complaint about malpractice or negligence when it came to a Botox and dermal fillers procedure. But I bet you have when it's gone to implants and porcelain veneers and just regular restoration. So it is very, very rare from a public safety, patient safety standpoint. Like I said, at this point too, we have 10, 12 years in dentistry where it's really become mainstream. And I actually spoke a few years ago at the American Association of Dental Boards. And that's the annual meeting of all the dental boards, as many of you may know, if you've ever gone to any of their meetings. And I spoke about the topic of Botox and fillers. And I remember the chairman of the session that I was presenting at He was the dental board president from Florida. Like asked this room of about 300 dental board members from around the country and said, even then, I mean, Botox and fillers had been in dentistry for a few years. It said, has anybody here ever gotten, a patient complaint, a patient safety complaint about Botox and fillers? And not a single hand went up. Then he asked about implants and every hand went up. So in terms of safety, it's got an unbelievable track record, which is why I think that, it's really one of the few things that you can actually teach. I mean, I and the AAFE, the American Academy of Facial Aesthetics, we teach this at the ADA annual meeting. We're doing it in the upcoming Las Vegas one. We've done it for the last 5-6 years, like I said, including in San Antonio when it was there as well. So it's a very safe procedure at the time of treatment. It's one of the only things you can actually teach live patient at a dental meeting. And it's a very, very safe procedure.
Thank you. Dr. Henderson?
So Dr. Brian Henderson, I have a question. Do you have a Texas dental license?
Myself, no.
And when you come in and give these CE courses in Texas, do you put this position statement in your lecture, or do you teach according to what you're saying, that you encourage all dentists to administer this cosmetic procedure?
No, we teach the Texas dentists exactly what is in this position statement, but we also teach them what's in the Dental Practice Act. And we teach them how to document appropriately so that they will stay within the scope of dental practice. But we do make this statement known to them. I think most of them know what's in it there. But again, if you had the time, I'm happy to take you through this statement, and I can show you how it talks in double negatives, and the statement absolutely makes no sense. And for the most part, if you want my honest opinion, this statement allows dentists to go ahead and treat skin, if you want me to take it through there, and do microneedling and skin treatments the way this policy statement is written. And I'm sure that's not what you all intended for that. So,
Doctor, are you also an attorney?
I am not, but I know how to read, and I know these statements, and I probably know the dental practice acts of most of the states. Well, I'm used as a consultant for many dental boards around the country, as well as AGD advocacy and that kind of stuff. But I do know dentistry, and I do know these dental practice acts.
Okay, thank you.
Mrs. Yes.
Yes, thank you, Dr. Burke. Lauren, a quick question for you about this. The statute that you have in the file that I've looked through doesn't mention anything about it being acceptable or within the scope of dentistry in Texas for Botox or fillers. Did I just miss it in the statute?
So the statute isn't in your materials.
Where did I get it then?
Okay. Are you referring to the board's policy statement and the statute that's cited in the board's policy
Oh,
statement?
yes.
So according to the policy statement, they took that language from the statute. What section was that? 251.003.
Right.
And back in 2010 said, based on that language of the statute, we determined that the use of facial cosmetic procedures is outside of the somatognathic system and not within the scope.
Yes.
At that time.
And I understand that the 87th legislature updated this statute.
There's been no updates to this section of the statute.
Okay.
Dr. Henderson?
Thank you, Ms. Sisk, because that's exactly where I wanted to go, because the statute isn't in our literature, and he says it obviously differs from what his interpretation of the policy. So I'm going to ask Lauren if she would agree or disagree to the accusation that the policy statement is not out of statute, or it is statute, or where do we stand with the policy statement compared to the statute? Because it reads that it was taken immediately out, and there isn't a contradictory problem. I didn't know where he was getting his information that was made up.
So, I mean, I think it was their interpretation, the board's interpretation back in 2010, that according to section 251.003 of the statute, which defines the practice of dentistry, that's what they based this policy statement on. And back in 2010 decided it was outside the scope of practice.
One more question. Lauren, I looked up the bill, the House Bill 2056, that was amended in this legislative session, the 87th. It actually does amend the 251.003. And that's what my question was.
Okay, so I think you're referring to the
Amend.
ministry bill that was just passed. That was.
Yes,
Okay, yes, that's specifically
yes.
talking about teledentistry.
Yeah. Oh, teledentistry only. Okay. I didn't go through and read the whole thing. Okay, good. Thank you. Thank you.
Thank you, Ms. Sisk.
Well, I just want to point out that the second half of this policy statement is not based, and that's what I'm speaking to, is not based or mentioned at all in the Dental Practice Act. That's the interpretation the board had at the time for that. The term stomatognathing system is not mentioned anywhere in there. The term isolated cosmetic purposes is not mentioned in the Dental Practice Act. I mean, nowhere does it say any of those things in the Dental Practice Act. I mean, that's why at the time they had this. And the position of, I would say, outside of Botox and fillers, anybody calls the Texas Dental Board as well as calling any other dental board, and they say, can I do this? There's something new out there. There's dental lasers, for example. There's this or that, the other thing. There's not an argument that says, well, no, you can't do dental lasers because doesn't say you can do it in the Dental Practice Act. Then no one ever said you can't do dental whitening because it doesn't say that in the Dental Practice Act. What most boards say is, listen, you can use any pharmaceutical, you can use any medical device that you want as long as it's within the scope of dental practice. Your Dental Practice Act would be, thousands of pages long if it actually went and listed absolutely everything that it can do. And that's not what a Dental Practice Act typically does. And Botox and fillers are just tools. They're like a restorative. They're used for different purposes and completely used within the scope of dental practice. And certainly we know that on a national level because, been teaching it at the American Dental Association. I don't think you can get much more about dentistry than that. And at the AGD, this is well established now in dentistry in many journals and that kind of thing. So, second paragraph of the policy statement has, in my opinion, it's only their interpretation. There's nothing even close to that within the Dental Practice Act. None of the wording in that second half, the second paragraph in the policy statement is reflected in the Dental Practice Act.
Thank you.
Just as a reminder for the committee, our general counsel's recommendation is to not make any changes to the policy statement. We don't really need to argue the semantics of the policy statement. Her recommendation is either to remove it and do some rulemaking, or remove it and let our dental review panel determine whether the standard of care is met in Botox cases.
Okay. Thank you. Thank you. And just for a little bit of history, because I want to make sure everybody understands the policy statement was approved April 16th of 2010. That was when that was approved. But thank you so much for being here and presenting for us today a second time. Appreciate
My
that.
pleasure. Thank you very much. Let me know if I can help again.
All righty, thank
Thank
you.
Take care, everybody.
And I think it's important that we remember too, as Lauren stated, it's a non-enforceable policy statement. We need to remember that as well. Yes, Dr. Yee?
Well, I just feel like this thing is overblowing because no matter who does it, no matter what happens, we are beholden to the Dental Practice Act. Everything we do has to be justified for dental need. And, this is one of the least invasive things that we can do as dentists because, implants, wisdom teeth, surgical therapies, even cutting a tooth is more invasive. So, I would just recommend eliminating this policy statement and letting DRP evaluate case by case.
Could I
Yes.
go on ahead and move that? Or
Yes.
do we have to vote on it or not?
We can make a motion.
Oh,
make a
yeah,
motion.
can I make a
Yeah.
motion that this policy statement gets approved?
Okay, so Dr. Maldonado has made a motion to eliminate or remove the existing
I'll-
policy statement.
I'll second
regarding
that.
Botox, seconded by Ms. Lois Palermo.
Open up the floor for discussion.
Okay, at this time, is there any discussion? Dr. Henderson,
Could you repeat the motion?
the motion was made by Dr.
Right,
Maldonado.
but what,
It is to eliminate the policy statement on Botox.
To remove it,
To
and
remove it.
Ms. Nichols, you said to
Allow
defer it to
DRP.
DRP,
Mhm.
and I'd like to add that.
Any complaints that we have related to Botox would be referred to our.
Right.
Thank you. Is there any discussion?
Yes,
Oh, hi, Mrs. Yes.
thank you, thank you. So we will, this motion is to remove the policy statement and just let it, that's it? No rule, no, and just wait for a complaint to come into the DRP? Is that what we're voting on?
That's a great question, Mrs. So basically what it is, we would remove or eliminate the policy statement and allow our Dental Practice Act, or in statute, we would allow it to speak for itself in that Botox is allowed in dental therapeutic cases. And so if there's ever a standard of care issue with a particular stakeholder or provider, that would come before the dental review committee and then be dealt with on a case-by-case issue. Does that make sense?
It does. Is dental therapeutic, which the little phrase that you said, is it defined somewhere? That's pretty wide open.
Well, the problem I think we can all appreciate is it's very difficult to distinguish or differentiate when you're using Botox to
Yeah.
use it for a dental therapeutic situation, because it does go hand in hand aesthetically. So I know our Dental Practice Act states that we want that to be limited to dental therapeutic, but in most cases, the patient will be receiving an aesthetic result as well. I don't know if it's actually listed anywhere. I think it's very broad in our statute. Dr. Henderson?
so, as I read that mission statement, and we don't have an oral maxillofacial surgeon sitting on this committee, it is clear in the Dental Practice Act that oral maxillofacial surgeons can do cosmetic. Correct?
Yes, they can do aesthetic procedures from the way I interpret it.
It is.
I agree,
It is.
because they're an FD as well, so.
Well, they don't have to be.
No,
Right.
Yeah.
So I just wanted to point that out. By removing this, are we trying to say that oral surgeons cannot do Botox aesthetically?
No.
We're just allowing people to
Anybody.
have this discussion on looking at the Practice Act and decide whether they're doing it as a therapeutic procedure or a cosmetic procedure.
Right. So what we're doing is taking a non-enforceable policy statement off of the website. We're not saying, yes, somebody can do something, no, somebody cannot do the other. So yes.
Exactly. I wanted to make sure that we're not trying to send a message to the oral
We're
maxillofacial
not.
surgeon.
No message.
No. Dr. Yu, did you have a comment?
Oh, I think you answered my question.
Okay. All right, so if there's no further discussion, we have our motion and our second on the floor. And do we go person by person to vote, or do you like it?
You can just do a show of hands vote.
Okay, so all those in favor, by show of hands, they say aye. You don't feel pressure, sorry.
Okay.
You called-
Yeah,
you called
say
it
the
in.
motion.
Yes.
For the
Okay.
for and
So
against.
four is Dr. Brian Henderson, for Dr. David Yu, for Dr. Yvonne Maldonado, and for Mrs. Lois Palermo, and for Dr. Linda Burke. So it passes unanimously.
And Mrs.
Mrs.
Mrs., there you were, I forgot you, I'm so sorry. And for Mrs. Thank you, Mrs. Okay, so the motion passes unanimously. Righty. So now we're going to move on to our second agenda item, and that's committee recommendation and possible action on residencies and the practice of dentistry. Ms. Casey Camp, will you please lead our discussion on this topic?
Sure, Dr. Burke. As you all may know, past couple board meetings is a question of whether or not residencies for the purpose of licensure for credentials or by credentials, excuse me, may count as the practice of dentistry in the requirement of practice prior to application of 3 of the last 5 years. Very, very narrow question is what we're looking at. The short answer to that is on its face, no. That's based on, again, some of the same sections we were just talking about, 251.004, which specifically defines what is not the practice of dentistry. Subsection 9, it's related to, directly related to residents. So a dental intern or dental resident as defined and regulated by board rules. However, that as defined and regulated by board rules, I think does give you all potentially some room to say, okay, how do we define a dental intern or a dental resident? What does that look like? And is there a possibility that certain residencies, certain acts that are taken during those residencies really aren't so much as purely educational, but it's really the practice of dentistry based on potentially what those dental residents do on their day-to-day basis, how they're handling patients, and the amount of oversight from instructors that they have. Our rule in 101.3 also seems to contemplate that this may also be the case because it says that any practice for the requirement for licensure or credentials must occur subsequent to graduation from a CODA accredited dental school. I think there's certainly some contemplation that by the legislature and by past boards that says we really don't want to count, your time spent getting your DDS or your MD as a practice of dentistry for these purposes, but maybe there's a world in which we could count residencies. So this leads me to what should you all do about it, nothing, or if anything. And if you've reviewed my memo, I have several recommendations, possible recommendations for you all, including, yes, I think you certainly, based on Dental Practice Act and on board rules, have the ability to carve out what is a residency, what really isn't. And that would task you all with probably a pretty uncomfortable and difficult task of determining where that line is. Other states have taken several different looks at this. Mostly states are aligned with our Dental Practice Act. They do not consider time spent in a residency as the practice of dentistry for licensure by credentials or by an ordinance. But at least to California, explicitly permits residency to be counted as practice. Colorado says they'll look at each residency on a case-by-case basis. So your second option would be to adopt a rule similar to Colorado's that says we'll consider residencies on a case-by-case basis as a practice of dentistry for licensure by credentials. The third option is to, of course, do nothing, continue what you're doing. Some of you sat on our licensing committee earlier today, saw how the exception process works. You can continue to treat these as an exception to board rules to the practice requirement. And I think the most logical thing to do there would be to direct board staff to do a little bit more information gathering whenever these cases are getting ready to go to the licensing committee, specifically concerning course curriculums, whether or not they were received a stipend or a salary for that period of time, and any other information that you believe would be pertinent to you to say, okay, this was really more of a practice experience versus an in-classroom learning experience. And then I would strongly recommend that you all consider the last option of continuing to consider these as exceptions to board rules.
Thank you.
I'd like to make a comment. I think the important thing to remember with this is every residency program is obviously so different. And in my particular residency, I'm just going to speak from example. We were 5 residents, 3 were stipend, 3 of us were stipend and 2 were non-stipend, but we did the same workload. Whether we had to treat the same number of patients, do the same amount of research, we all sat through the same classes. And so I think it would be very difficult and complicated for us to try to delineate what a true residency is, how many hours they're in the clinic, how much research they're doing, and that sort of thing. I think it would make it difficult. The other thing I wanted to mention was allowing our staff or giving them the directive to gather information, I think is an excellent idea, especially in seeing that the actual resident was completing their undergraduate training at a CODA accredited university. I think that's very important as well. But does anybody have any comments? Dr. Yu?
So are we looking at an internal direction, or we're not looking at like a rule or an amendment to a rule?
Correct. It would be an internal direction to board staff to gather
I think
information that you find.
My feeling about it personally is that yes, they're students as residents, but they've already earned their doctorate. They could legally go out there and practice on their own without direction. And so, from a residency standpoint, I mean, they've already gotten their degree and they could literally open up shop next door, because assuming that the licensure by credentials, that they've already taken their regional boards or national boards, and they're trying to get into Texas. And if they're doing residency, let's say a 3 or 6 year residency, their time is ticking on it. And what are they going to have to do after, let's say they're an oral surgery resident? And I know we're handling this internally now as far as stipend, but they're going to have to retake their revs, and they haven't done a class 2 filling in 6 years at least. So that's kind of the issue, is that you consider these resident students anymore, or they doctors.
And I'd also just like to remind the committee that we're talking about an extremely narrow number of applicants by credentials that would not meet the practice requirement by just practicing the past 3 of the 5 years, right? So it's a very small number of cases that we're really looking at. And I do think the appropriate place to consider this would be as an exception to board rule for that very reason. Certainly a mitigating factor that these particular applicants are already licensed, have already passed their boards prior to going to a residency. I think those are all extremely important things for you all to consider. But unfortunately, our statute, our Dental Practice Act, our legislature has said this cannot constitute a practice of dentistry. So as we talked about earlier in licensing 2, another good conversation would be to have with some of your legislatures to say, we don't want to consider this not the practice of dentistry. Maybe we do. But as of right now, it is strictly prohibited by statute to consider it without going through and doing the difficult task of drawing lines as far as what constitutes a student versus a practitioner.
So, Dr. Yu, I can certainly appreciate your contemplating, and you're right, but there are a lot of people that graduate dental school and never activate a license. So you may say they can go and practice while they finish their residency. They may not be legally able to do so. And therefore, if they're doing a residency and didn't want to activate a license, I'd say clearly they didn't. Any of their residency had any form, because they're using the attendance license to do what they want to in the school. And then you add the foreign trained guy that is doing the CODA Prod residency, who got their dental degree in Guam or Barbados or some other place, and they come here and do a public health residency. Now they went to a CODA approved residency, and then they want to do it and count those years. So I really think we ought to just stay with the legislative
But that's a different deal, Dr.
Well, I understand, but
Foreign graduate.
that's because you're starting talking about a license and counting years of practice as a resident. And we don't necessarily, you start getting into this narrow deal of which resident is practice of dentistry. Is it an anesthesia residency of practice of dentistry?
No.
Right. So, right, exactly. So I really think it's best just to do nothing with this and let the statute speak for itself rather than try to
So I
write a
would
rule.
say I agree, kind of case by case situations, you know,
Well, that's why we have the exception to licensing and let it go through licensing.
right.
Ms. Sis,
Yes, thank you. And I agree. I think we should just do nothing right now, leave it alone and let the statute speak for itself. And do, it's on a case-by-case basis. I was a member of the licensing committee for a while, and we had several of these cases, and it was interesting. But it's good to do them on a case-by-case basis because each of them have different personal issues and reasons and backgrounds. And so I would prefer to leave it that way. But I would ask that the staff go off and do the background requirement, the documentation, and get us more information about, to aid us in determining that exemption if it's going to come to that. So that would be my preferences.
Need a motion from Ms. Sis to do that, or we just have that as communication?
Communication.
Perfect.
I can make that a motion, certainly will, to leave it as it is right now, just what I said. If you want to use it a little bit differently, that's fine.
Yeah. Ms. Nichols thinks it's appropriate that I think is a consensus with the committee, and we can leave that to the chair to make that decision if she wants to take a roll call. But I certainly agree with your annotation that let the staff gather that information should it become necessary in a licensing exception.
thank you, Ms. Sis. I agree. Would it be better to just have a motion? Or is that a non-action item?
It's not really an action item.
Not-
You're not really, I mean, we already gather this information when we have a
Okay.
licensure
So we're
question.
leaving that.
So I mean, it's kind of voting on something we already do.
Okay. So then-
Yep.
Okay, so we're gonna move on to our last agenda item. Thank you, Ms. Sis, for your input also. Now we're gonna move on to our committee recommendation and possible action on Rule 108.7, which deals with minimum standard of care. And that will be Ms. Studdard. Will you please lead our discussion on that?
That's Dr. Burke. So this rule amendment is simply to remove the emergency rule language pertaining to COVID-19. The rule will officially expire tomorrow, June 18th, 2021. It's our understanding that the board doesn't plan to renew or update the emergency rule. The amendment would no longer mandate that dental professionals follow the listed guidelines pertaining to COVID-19.
Dr. Henderson?
Make a motion that we adopt the rules proposed.
Second it.
Second, the motion was made by Dr. Henderson, second by Ms. Sis. And I'm gonna call roll.
Open discussion.
Oh, discussion, sorry. Any discussion? Okay, Dr. Yu.
Well, obviously, this all came about from Executive Order, 34. And I think it's important for the board to let the public know that they still need to, look at the CDC guidelines and just kind of follow everything, as far as what they recommend. And the guidelines are different for fully vaccinated versus not vaccinated.
And that's a good point. I do think Ms. Nichols, when she sent the email out, stated that it would be updated on our board website to let stakeholders know that we still are to follow CDC guidelines.
Yeah, and interesting that the CDC also mentions teledentistry, but we'll get to that later.
It's coming.
Yes, but that's a good point, Dr. Yu. Thank you. And Ms. Palermo?
I just wanted to make one point, maybe, and I'm not quite sure how to do it, but I'm thinking on Ms. Nichols, because one thing that I saw throughout this COVID thing was I kept hearing from some dentists, they're like, well, it doesn't matter what the board says, because we have to follow what the federal government says, and the federal government supersedes the state. And I'm like, yeah, but I don't think that's the state. or that's making rules pertaining to dentistry. So I think if there's some kind of clarification on those things, because it's like, I know several dentists that once the CDC came out with their stuff, they said, to heck with the board stuff. Like, they just did away with everything before we've even gotten.
Well, the CDC issues guidelines. The
Right.
CDC has no authority over the dental license like the state board does. So it would not behoove a dentist to just follow CDC guidance, because that's all it is guidance.
Well, I think that's where the problem lays, because I don't think they understand the difference between federal and state and who they should be listening to sometimes. Well, at least through the COVID problem. I mean, yeah, because a lot of times the CDC wasn't always in conjunction with the states. And, you know, that's where part of the confusion led to, and they just picked what they wanted to sometimes.
Well, ultimately, they should be picking what the board, they're under, their license is regulated by their state board, and that's who they should be concerned with in those instances. But we will be happy to educate people if there's a recommendation from the committee or the full board. I mean, I know now we're kind of getting away from our COVID protocols.
Right.
So,
Right.
but should, God forbid, something like this happen again, we're always up for educating our licensees as needed.
Or when we get rid of this, say on the website that you should still be following CDC guidelines.
Perfect. We'll be happy to do that.
So basically, I'm gonna recap it.
Okay.
Okay, so we're gonna have our board staff update the COVID-19 guidance on the website and encourage licensees to adhere to the current CDC guidelines for dental settings.
Yes.
And that is also, I believe, an action item.
Yes. And we're taking out verbiage from 108.72, which was part of Dr. Henderson's motion.
Yeah, we did.
Okay. Was there a second? You seconded it, right?
Yeah.
We're in discussion.
More discussion.
Okay.
Okay, any further discussion on that? All right, so I'm gonna just go call roll, it's better. Okay, Dr. Yvonne Maldonado.
So I just wanted to, can you reiterate what the motion
Right.
states before we vote? Is that okay?
Yes.
So the motion was to accept the rule as written by staff for 108.7, with the amendment of the lines being marked out. Nothing was added, just removed.
So that's it.
And I can tell you it's section 16,
Its emergency rule will expire.
correct.
Okay, yes, okay.
Okay, so Dr. Yvonne Maldonado is for. Dr. Brian Henderson,
Or
Ms. Lois Palermo,
Or
Ms. Catherine Sis,
4,
Dr. Linda Burke for, Dr. David Yu.
Or
So the motion passes unanimously. Great. This time, I'm going to move into any public comments that we may have. Do you have any public comments?
Yeah,
Dr. Clemens? Okay. Dr. Clemens would like to speak to the committee if you're ready.
Okay, yes. Dr. Clemens?
You got to get it.
David Yu. So the motion passes unanimously. Dr. Clemens? I'm going to move into any public comments that we may have. Hello, Dr. Clemens?
Yes,
How are you? You're here now with the Dental Practice Committee, and
Yeah.
We would like to hear your comment, but please be aware that we would like you to limit your comment to 5 minutes.
okay, I have no comments in this asked.
Okay, thank you so much.
Thank you.
That's it. Any announcements?
And you know,
Okay, Dr. Henderson.
thank you, Dr. Burke. I want to congratulate Dr. Burke as the new chair of the committee. So I look forward to working with you. And Dr. Maldonado, welcome to the board. I look forward to working with you as well. And of course, Ms. Palermo, so excited to have you on this committee, as I'm the old person. Yes, yeah, you're the PO. Congratulations. Announcement, I just wanted to,
So,
and staff doing a nice job.
and no comment on the laser dentistry.
Nobody asked to speak publicly. It's just a written comment for the committee to consider.
Do I get CE hours on jurisprudence from reading Cassie's report on all that legal? I just want to know, surely that's worth 4 or 5 hours.
The bar too.
The place
Well
is
done.
jurisprudence.
No other comment.
Okay, so do I hear a motion to adjourn the meeting? Okay, Dr. Maldonado, a second by Ms. Lois Palermo. All in favor, show of hands. So unanimous. So our meeting is now adjourned and the time is 1:49 p.m.
Safe travel.
Thank you.
Great job. Thank you so much.
Thank you.
Thank you,
Thank you, Ms. Fisk. We'll see you
Thank you.
tomorrow.
I will actually see y'all tonight. I'm gonna get in my truck right now and drive up. So I'm on my way.
I apologize for not recognizing you as well.
Oh, that's okay.
I forgot about.
We'll talk about that later, okay?
Thank you. Safe travel.
Thank you. See y'all later.
Thank you.
Go ahead and unmute. We got a-
This is Dr. McNeil. I'd like to call the June 17th, 2021 Disciplinary Review Committee of the Texas State Board of Dental Examiners to order. The time is now 2:03 p.m. I wanted to remind you all, let's keep our computers here locally on mute. We'll use the other speakers that are there. If you have a comment to make, please raise your hand and I will acknowledge you at that point. I'd like to go ahead now and read the mission of the Texas State Board of Dental Examiners. The mission of the Texas State Board of Dental Examiners is to protect the public health and safety and promote high quality and safe dental care by providing enforcement, licensing, peer assistance, and related information services to licensees and their patients. I will now call on Ms. Nichols to perform roll call.
Thank you, Dr. McNeil. Dr. Robert McNeil.
Present.
Dr. Yvonne Maldonado.
Present.
Dr. Margot Melcher.
Present.
Ms. Marquita Pride. We were previously informed that Ms. Pride had a prior engagement. She would not, it does not look like she'll be joining us. Dr. David Yu.
Present.
We have a quorum.
Thank you very much. Thank you very much. Okay, let's move on to item number 3. And I guess a preamble to that, thank you to the new members of the committee. I was on this committee with last session, and we came out of the disciplinary matrix reformat during that time period. And so I thought, since we had some new members, this would be a great opportunity to sort of bring in some of the board staff to give us sort of a highlight of what we do from a disciplinary standpoint and to talk through the process a little bit. Are we prepared? Would be best to have Dr. Bell go ahead and go through the investigations and dental review panel component now?
Sure.
Okay, if Dr. Bell is available, I'd appreciate that.
I am here.
Good morning.
Good afternoon. In your materials, you'll find essentially my notes, what I will be summarizing from. Essentially, when we get a complaint, cases are first evaluated during the preliminary investigation phase by both an intake specialist and we have an RN analyst who manages the case at that point. You know, if the case is a self-report, then we would analyze it to meet that criteria. You know, is it a possible consequence of dental treatment? Was the patient admitted to the hospital? Those types of criteria. And then if it was not a self-report, then the case would be, the jurisdiction of the case would be considered. Some examples of a non-jurisdictional case would be a fee dispute, the wrong respondent named, you know, perhaps the complainant wrote a dentist name who never treated the patient, or perhaps the named dentist never had a Texas license at all. So once cases are found to meet those basic criteria, if they're received as a self-report or if they're received as a complaint, They are then moved on to an official investigation. And at that point, it essentially gets assigned to an investigator. And I'll use the terms investigator and analyst interchangeably. Analysts are essentially desk investigators. They don't tend to go out in the field and collect records, whereas with our nomenclature, the investigators tend to be the ones that go out in the field to collect things. But essentially, aside from that one fact, their jobs are very similar. So once the case is assigned to an investigator, we continue to collect and evaluate the evidence. The case could still be closed at that point as a baseless complaint. And just as a reminder, either the dental director or the director of investigations has to sign off on all case closures. I happen to be both right now, but hopefully if we get a director of investigations, either one of us could really sign off on those closures. And we tend to review the cases that most apply to our area of expertise. So in the future, I would probably review any dismissals that involved any kind of patient care, and the director of investigations would review cases that didn't appear to have any patient care involved. Once the investigation is complete, they've tied a nice little bow on the evidence, as in they've made it into a PDF that we call our Consolidated Evidence Document, or CED, you'll hear. Once that it has been put together, it is then submitted to, we have a program specialist who's also a registered dental assistant, Kendra Owens. She evaluates the case to make sure everything makes sense, the records are in order, x-rays are turned the right way. Sometimes it's difficult for our analysts and investigators to verify that, make sure. And then she also summarizes the case to prepare it for DRP. Again, she may recommend cases for dismissal at that time if she then finds out perhaps the wrong respondent is named, or a variety of circumstances. But we continue to analyze it. Can this case be closed? Should this case be closed, essentially? But again, only the dental director and the director of investigations can sign off on those closures. So Kendra also points out anything special that we need DRP to opine on. She'll put the basic allegations at the top of her little blurb. And then if there are multiple patients, she'll make sure and let them know, hey, please use the multiple patient format. Any exceptional items she'll point out. She'll also point out any records that, maybe she had trouble finding that were important, notion number. Just trying to make everything flow for DRP and be as easy to work with as possible. And that, as you know from ISCs, that document is a PDF, but it's also bookmarked. So that also makes that navigation hopefully fairly straightforward for DRP. So once Kendra reviews the documents, and then I do review those right at the end before they're put in the queue to be assigned to DRP. Once DRP receives a case, the case actually goes to at least 2 DRP members. 2 out of the 3 DRP members need to agree and designate one single report for that case. If it's, the members do not see the actual complaint, they see a summary, they see a list of allegations. And that's whether it's a self-report or a complaint. Again, we receive them from different sources, but essentially they flow down the same path. And so again, DRP has an obligation to follow a format that we request. Again, we're trying to make sure all the information is there for you guys when you sit for an ISC. And again, it's easy to find. It looks similar. You're not having to dig around in a lengthy paragraph to try to find out if the reviewer felt there was a violation or no violation. So again, everything is just for to try to make the process efficient and as simple for everyone else as it goes down the line. I always make sure my staff, I'm like, if you put a lot of time into figuring something out, tell the next person. And that way, you know, when y'all get the case, you're not digging for, oh, was there a time-oriented anesthesia record or not? You know, it's all there for you. So the case report is written, and then the case will go to a queue where it waits on Jessica Menchaca is my main staff person that helps me with clinical matters. She's a registered dental hygienist. So the case is set in the queue for either Jessica or myself. We analyze the report to make sure it follows our format, make sure things generally make sense, make sure the reviewer didn't upload a report that was for a different case or anything like that. If there are no violations found, then we will close the case within the division. And tomorrow at the very bottom of my report, you'll see a list of cases, and that's what those are. DRP reviewed the case, they designated one report, they said there were no violations. If there are violations found, then we evaluate the case for either pre-ISC evaluation or set it for a regular ISC date. So we try to categorize, you know, branch off into those two main categories. And that really concludes my part of the process. At that point, it goes to legal, and Ms. Studdard could take it from there.
Dr. Bell, so once legal receives the case, it gets transferred in 3 different ways. The first way is pre-ISC process. The second way is through the ISC process. And the third way is at SOA, which is the State Office of Administrative Hearings. So the first process is pre-ISC process. It's broken up. The cases are broken up in 2 different categories: standard of care cases and non-standard of care cases. The standard of care cases are reviewed by a board member, and they make a recommendation to resolve the case either by dismissal or public action. The non-standard of care cases are reviewed by a staff attorney, and then they will make a recommendation to resolve the case either by dismissal or public action. The ISC process, cases are routed to an ISC from either the dental review panel has determined that there was a standard of care violation, and Dr. Bell determined that the case warrants an ISC, or a pre-ISC case that's settled and the respondent has requested to appear at an ISC. The SOA process cases are referred to this to SOA kind of 2 different ways. The first way is that cases are not settled during an ISC. So if a respondent doesn't wish to settle with the board, the case is then set at the State Office of Administrative Hearings. The second way that a case can go to SOA is that legal sets cases directly at SOA instead of transferring them to an ISC. For example, we have criminal history cases that we set directly at SOA, or cases where there's an imminent threat to a patient and staff needs to seek a temporary suspension of a respondent's license. And so that's the gist of how cases are transferred through legal.
Great, thank you. And I think that entire process is something over the last several years as a committee, and certainly as a board and as staff, we've tried to figure out how do we make that system as efficient as possible? How does it give us the ability to effectively, efficiently, and timely deal with some of the more significant issues that we need to deal with? And I'm really proud of the last committee and staff and the board for really helping efficiencies with that entire system. And it's been nice having sort of a dedicated person for ISCs to help with that. Any other comments from legal on that process? How are we doing as far as caseload? How are you doing with ISC dates?
I think we're doing great. I think we are seeing a lot of 2021 cases and less of older cases. So I think Dr. Bell put it in we're seeing cases in real time, a lot more cases in real time. So I feel like we're in a really good spot.
Any questions for staff at all based on that discussion? especially with the newer members.
Just out of curiosity, Ms. Stutter, what is the where are we at as far as, do we have any 18 or 19 cases that we're still on?
I can look into that for you. I'm not sure what the breakdown is of that.
But kudos to y'all for getting caught up, because I know that I was scheduled for one in October and they said they canceled it. So that-
I can field that question, since I do this with the scheduling. The answer is yes, there are very few 2019 cases that are getting ready to go to an IFC by the end of summer, early fall. There may still be some more. Dr. Bell may be able to speak on that, but yes, we do still have a few that we're working through. And then we also have some older cases that are standard of care cases that have already gone to an ISC that just need to be resolved through the SOA process. Very proud to say that our attorneys have been working really diligently this whole calendar year to get those cases on file. And I feel fairly confident that most, if not all, of those cases will be on file with the State Office of Administrative Hearings by the end of the calendar year.
And just a point of clarification that the SOA was closed down for a while due to
Yes.
the pandemic, so that did put us correct.
Dr. you had a comment.
I wanted to recognize Dr. Bell again. She's wearing double hats and with no end in sight, I'm sorry. And, for her work in investigations and dental division. But by statute, we have to do, as far as the caseload, has to be 180 days or less. But last time she was like at 70 days or something. That's pretty amazing. All the work that you've been doing with little help. Well, as far as like personnel, but we were going to talk a little bit about probably tomorrow about doing ISCs virtually also, and I wanted to see what y'all's thoughts are on that as an option.
Anyone that could, Dr. Mulder?
Well, I've never been to one, but I think that would be a great option for everybody, all parties involved. But that's just my opinion without having been to one. But
Well, and it's, for us, it's more just an option from, respondents and their attorneys, for instance, and usually board members will be here.
Post-COVID, many things
Yeah.
will change forever, I'm sure. From a legal team side of the equation, do you have any strong opinion one way or the other on that?
I think it's been working really well. You have people show up in person and also by Zoom. It's been working really well.
And I think certainly if you look at efficiencies of the system, a variety of different ways, that can be appropriate, but give us some flexibility there. So what I hear the consensus is moving forward, people, both respondents and board members will have the option of virtual versus in person. And there's pros and cons to each of those, I think. Any other questions, Dr. Muncher? Did you have a question or comment?
Just for the director of investigations, are we going to be hiring for that position, or is that?
So, sure, I can answer that. We unfortunately did not receive that position from the legislature, but we are going to try to move some things around internally to fill that position with some of the FTEs that we did receive. And hopefully take some of the burden off of Dr. Bell's plate.
So it won't be a director position, it'll be more of a.
Our thinking is that it would be a director position, and we just wouldn't be able to offer the salary that we've previously been able to offer until we get more funding, but it would still be a full director position.
Dr. Mulder?
my question was answered.
And I think it does, especially for newer board members, it takes a while to kind of get used to that ISC process. And, I commend y'all with your help, and then the committee last time around was sort of developing that pre-ISC dismissal process. And it's a little bit of a back and forth that took a little bit of time, I think, for all of us to kind of feel comfortable with that. So you may show up at an ISC and they have a bunch of documents for you to review, case details, and say, okay, is this something that should be dismissed, or is this something we should offer an administrative penalty and not have people come to Austin if it is a lower level type of offense there. So
And legal will invite our new board members to sit in on some ISCs for training before, you actually sign up for one where you'd be having decision-making responsibilities.
And I think I would certainly have to commend our legal team during the ISC process that y'all have given an appropriate amount of sort of independent feedback with, giving your opinion, and then us as board members, we look at things in a slightly different way. And I think that's one of the benefits of us as board members being in person, to be able to kind of have those slightly easier conversations, at least especially at the start. It just makes it easier. But
Dr. McNeil,
yes, go ahead, Chris.
so in looking at the report that was in here, as Dr. Bell stated, on the part number 3, where it does say that once the case has been completed by investigations, all the evidence is examined closely again by an RDA. Is that an RDA on staff here with us, or is that like through the DR, the panels that we have?
I guess we'll have Dr. Bell answer that question if she's available there.
Thank you. So yes, that would be our program specialist, who happens to also be an RDA, Miss Kendra Owens.
Okay.
So that would not be DRP. That is a staff member. She's under investigations currently.
Great. I just wanted to make sure, because then I didn't know, are they just merely gathering the packet together, or was there some, the language that they're looking at and making sure that they were familiar with what the case all involves, and the complaint, what the investigators had saw needed to go forward. So just making sure that it was someone that was well, I guess, versed in the language and everything like that.
Yes, absolutely. There's absolutely some critical thinking that goes on with what she does, and she's actually doing a fantastic job. I think I don't speak about it in either of my reports, but her queue, which are essentially the cases that are ready for us, waiting on us, is also down to like 20 cases. So she's doing an excellent job, and probably, a pretty important job actually, because again, she summarizes everything for DRP, including the complaint that they can't see. And then I look at those as well before they go. So between the two of us, I think we get it squared away.
Thank you.
Were there any other comments on any case resolution improvements, or we sort of summarized what we're doing and we're certainly moving in an efficient way? Is there anything our committee needs to be doing? Okay, terrific. We'll see no further comments. Let's move on to line item number 4. And this is a discussion of possible action on Senate Bill 1534 that pertains to the remedial plans. I'm going to look to our legal team to see which one of you would like to talk about that bill and how we start out to move forward.
I'll summarize it. So the SB 1534 is in your materials. It will be effective starting on September 1st, 2021. So before the bill was passed, licensees were allowed to enter into only one remedial plan with the board. So this bill changes the law to allow licensees to have more than one remedial plan if the licensee hasn't entered into a remedial plan with the board in the preceding 5 years. It also allows the board to remove the remedial plan from the board's website on or after the 5th anniversary of the date the remedial plan was issued, as long as the complaint wasn't related to the delivery of healthcare, or there wasn't more than one remedial plan issued to resolve complaints alleging the same violation. And board staff plans to have a proposed rule amendment to our remedial plan rule that incorporates this language at the next board meeting in September.
Questions, comments, Dr. Yu?
So are we proposing a rule now, and then, or is this?
It'll be not now, next meeting. Yeah.
And just FYI background, this is the right thing to do, because the original sunset bill for medical 1504 was had this exact rule in it, and for some reason dentistry didn't have it. And this particular rule is sunsetting at 5 years in your remedial plans. Because we usually use remedial plans for like CE or non-disciplinary actions or record keeping or whatever. Unless, obviously there's multiple violations of the same kind or if it's related to healthcare. But I think, this is the right thing to do. And I just wonder, see, my question is how we go about it though, because are we gonna, is the board going to kind of track all of these remedial plans from here on out, and at 5 years, amend it, or does the licensee have to, petition to have it removed at 5 years? I'm not sure what the medical.
Yeah, I see it more happening the second way. If a licensee wants it removed from our website, they'll ask the board to remove it, and then we'll review the request.
I think that's
Do you anticipate putting that in the rule?
We can.
And that's why we did
Yeah.
propose a rule
Okay.
until we had.
And I think that's fair as opposed to having our IT people having to scavenge data. That's kind of fraught with challenges, I would think.
And just so the committee knows, before we get our rule solidified, the board staff can still enforce the statute. So should we receive a request to remove a remedial plan for somebody that qualifies under this new bill, we would go ahead and remove it, after September 1, just so everybody knows.
Any other questions or comments on that Senate bill? Dr. Melcher.
2 questions. So the first one was, who submitted this bill? And do we know who?
Senator Buckingham and Representative Campos.
But was it on behalf of a certain organization or an individual, or do we know the background of it? Just it appeared out of the sky.
We were asked to appear to give comment on it. Lauren and I attended that hearing, but they didn't need us.
I was just curious.
I think it just mirrors the medical remedial plan.
And part of what we've wanted from a disciplinary committee standpoint, we wanted to have a bunch of tools in the toolbox. We have this thing called an AAP, agreed administrative penalty, that we were hoping would be a nice little carrot that we could utilize. And this somewhat takes away a little bit of the power of that, but just gives us some options here. My concern is when we talk about it, having something to do with the delivery of healthcare, that's such a gray area. If someone doesn't take blood pressure before they inject a patient with local anesthetic, and that's the issue in question. Okay, it's a record keeping thing that it wasn't recorded, but is that clinical care? So that's, everyone likes gray areas until it's kind of an issue. So I'm assuming the rule would pretty much replicate this and then give us some guidance. And then the question is, if someone does want a remedial plan removed at the 5-year mark, they petition for that removal to happen. Does that happen at the staff level? Does it come to the disciplinary review to evaluate it and say yes?
Yeah, it's just an idea. I think it would work kind of like our modification of board orders, where it comes to an ISC and they make their case at an ISC, and then the ISC panel makes a recommendation, and then it goes to the board.
Is that an efficient use of time versus having them come through the disciplinary review committee?
Okay, we could do that as well. It's an idea.
Another idea is, if I may, is to give board staff the authority to take them down. If the person's met the requirement, if all requirements are in order and they petition and we get it, you can defer authority to the executive director or whoever you feel like the director of licensing, and they could file the ticket to remove it from an efficiency standpoint.
Now, a remedial plan should not be given to someone if it is really dealing with a significant issue of clinical care.
Exactly.
So it shouldn't really be something in the first place that's there. And, does anyone have any comments there? From my standpoint, dealing with it at an ISC and having the person show up at an ISC to get this removed may not be a good use of their time, our time, staff time, as opposed to we know the document, the board already said, okay, they've met the criteria for remedial plan to be an appropriate measure here. Okay, 5 years has passed, let's give staff, legal, the authority.
That's an excellent point too, in that the mindset's gonna change for our ISC panels, that now we know, if we recommend a remedial plan to someone, it's gonna go away in 5 years.
Will it be expunged where we will not have the ability to know that one was given?
No, board staff will know.
Board staff will
Public
know,
will know.
board members will know, just
So it won't be posted.
won't be posted on the website.
Right.
Gotcha. And that's probably a critical point there for us too. Dr. Yu,
Well, I mean, the other critical point is that if they've had a remedial plan, obviously, you know, if they get another one, even though it's been expunged,
removed from the website.
then, but, you know, the next one is going to be permanent and they have to be reminded of that too. But if they've had a remedial plan in the past, then they're ineligible to have the next one removed. Is that correct? Just to make it clear.
I think it's only if it's the same issue. They can't have.
Yeah.
Okay, it's same type of violation.
Right,
that's what it
right.
says, right. So they can have a remedial plan in the past, but it, you know, it has to be similar violations to
They can't get it removed if the complaint, so it's two. They can't get it removed from the board's website if the complaint was related to healthcare, the delivery of healthcare, or it involved similar violations to the remedial plan previously.
like if they have had a history of record keeping issues.
Right.
And get the same one.
Right.
then-
In that case, if you can't.
It really, this is where it's been nice having you all at ISCs where you help guide board members to say, well, here's our disciplinary matrix, here's our criteria of what we qualify for. a remedial plan. For instance, Dr. Melcher.
So my second question was going to be, is if a person comes in for an ISC, I know we usually see on their previous history that they had a remedial plan back in 1990 or something like that. Are we still going to see that? That'll still be visible, even though it'll be wiped off because they had called and requested it to be taken off the website.
Right.
It's only wiped off for the public, not for the board.
Okay. And then the other thing is, do we need to make a motion then for us to be able to grant the staff the authority to wipe these off or remove them from the website if someone calls and says or applies for the removal?
I think they're gonna work on.
We'll do that with
it.
rulemaking. We'll present the rule to you, we'll propose a rule to you, and we can just, at the next meeting in September, we can discuss at the September committee meeting, the language that we propose. And then if there's any changes that you'd like to make, we'll do it through the rulemaking process.
Okay.
Terrific. Dr. Yu.
I think another aspect of this is that when, you know, the spirit of this is that normally our remedial plans are once a lifetime. Although we've had, you know, but in this, you know, you could have every 5 years. So it's kind of another gray zone for us.
Right.
Well, seeing no further comments there, let's move on to any public comments. Do we have any public comments?
Yeah, I'm waiting for this. We're good. No public comments.
Okay. Any other comments from board members? Well, once again, thank you for attending our first disciplinary review committee meeting of this session. Dr. Yu.
Just a comment. Love the work you guys have been doing. You know, you guys made a lot of great changes last couple of years, and you know, appreciate, especially those sitting in front.
And to back that up, it has been terrific, and it's been, as I said, sort of getting a efficient use of everything we have here, and it's been interaction with board members and staff for sure. So, Dr. Melcher, is that a motion to adjourn?
Yes. Can I make a motion to adjourn?
Do I have a second? Maldonado. All in favor, say aye.
Aye.
Aye. Unanimous, motion adjourned, meeting adjourned. The time is 2:36 PM. Thank you, everyone.
Thank you.
Thank you.